Good morning. On the screen, you see the required disclosure slides. We will be providing the continuing education credit code shortly. And just a few housekeeping reminders before we get started. In the Zoom, please display your full name. Also, the session contains some preliminary data that may be unpublished, so please do not copy, screenshot, or record. And with that, I'm going to turn it over to Dr. Jean Bowman.
Welcome, everybody. It's my pleasure to introduce our speakers. My name is Gene Bowman. I'm the director of the Clinical Trials Platform and Brain Nutrition Laboratory at the McCann Center for Brain Health. And this is our seminar series where we have two guests here today from Duke University. Professor Murali Doraiswamy is a professor of psychiatry and geriatrics at Duke, where he directs the clinical trials unit. It's been involved in the development of many widely used diagnostics and treatments in psychiatry and neurology. He's also the co-author of a popular book called The Alzheimer's Action Plan. And Dr. Andrew Liu is associate professor of neurology and pathology at Duke, and they will co-present on the topic of the prevalence and predictors of ARIA in the real-world setting. Welcome.
I just want to add my welcome, Gene. I think we're really lucky, really fortunate to have two great speakers today, two of my favorite people. And Murali and I go way back, and it's just great to finally have you here speaking, and looking forward to it.
Thank you, Rudy, and good morning, everyone. It's an honor to be here and present at the McCann Center. I chose this topic, patterns and predictors of ARIA. It's a very clinical topic. I realize about half of you or three-quarters of you in the audience are translational or basic scientists. This is an area where we need more research, where we need more basic and preclinical and translational research, which is one of the reasons why I chose this. We don't have all the answers, and we're hoping that many of you in the audience will contribute to filling in the gaps in our knowledge base. So these are our disclosures. I want to acknowledge the Cure Alzheimer's Fund and the Duke UNC ADRC for supporting our work. So there are four aims. Professor Andy Liu and I will be tag teaming this presentation. I'm going to be presenting initially some background on amyloid-related imaging abnormalities. I realize not all of you are clinicians, so you may not be as familiar with this term. I'm then going to turn it over to Dr. Andy Liu, who is going to share the results of a real-world study that we did at the Duke Memory Disorders Clinic. And then he'll turn it over to me, and I'll discuss briefly the pros and cons of using artificial intelligence for detecting and tracking ARIA, as well as some preliminary data that we have on blood-based biomarkers for predicting ARIA. So this is a background. Much of the foundational work for what I'm showing in this slide actually comes from Harvard. So this is probably something very elementary for all of you. We know that the big breakthroughs occurred when the FDA approved two humanized monoclonal antibodies. Lecanemab or Leqembi was approved in July 2023. And it targets amyloid protofibrils, as you can see in this slide in the first blue arrow. Donanemab or Kinsula was the second drug that was approved. Again, I'm not talking about aducanumab because it's not used. So donanemab or Kinsula was the other major approval that occurred in July 2024, which is also a humanized monoclonal antibody. It primarily targets the mature plaques, as shown in the blue arrow on the top. Now, both of these drugs are breakthroughs, but the main factor that has limited their widespread use is this abnormality, is this adverse event that is now being called as amyloid-related imaging abnormalities. Again, the term was coined by a task force chaired by Risa Sperling and a number of others at Harvard, including Brad Hyman, and that's the reference given at the bottom. So amyloid-related imaging abnormalities, or the abbreviation is ARIA, can take many different forms. It can take the form of microhemorrhages, which is small areas of bleeding in the brain or hemosiderin deposits, usually under 10 millimeters in size, but sometimes it can be less than, much less than that. So it can be very hard to detect. It can also take the form of swelling or edema. This is called as ARIA edema. It used to be called vasogenic edema in the past, but now in this context, it's being called as ARIA-E or ARIA edema. They can also be macrohemorrhages, which are not typically called as ARIA. So these are frank areas of bleeding much bigger than 10 millimeters in size. And then there can also be some staining of the superficial layer of the cortex, which is called superficial siderosis. So these are the many forms that this abnormality can take. Now, this slide shows you the incidence rates of ARIA in clinical trials for the two drugs that I mentioned, lecanemab and donanemab. And you can see the incidence rate of ARIA-E is 12.6% and 24%. The incidence rate of ARIA-H, which is ARIA microhemorrhages, is 17.3 and 19.7. And then the incidence of any ARIA, some of these can occur at the same time in a given patient, or they can occur, by themselves. And so this incidence rate is what really has caused a little bit of a concern and a limiting factor. Even though the vast majority of them are asymptomatic, they can sometimes go on to become serious adverse events. Now, it's been known for almost 15 years that the major risk factor for ARIA, especially ARIA-E, is the ApoE4 genotype status. And this slide shows you the incidence of ARIA-E rates by ApoE4 genotype status. You can see non-carriers have the lowest risk. Heterozygotes have slightly higher risk. And you can see homozygotes have almost 2 or 3 times greater risk than non-carriers. The second thing that we have known for almost 15 years is that the speed of dosing also has a big impact. The faster you titrate, the faster you reach steady state, the higher the risk for ARIA. If you titrate slowly, as shown here at the bottom row with donanemab modified dosing, you can lower the ARIA rates. So monoclonal antibodies typically take anywhere from 2 to 4 months to reach steady state in the brain. So one of the problems is if you give it very fast, you increase the risk for ARIA, but you also increase the chances of getting an effective signal. If you give it very slowly over long periods of time, then your efficacy might go down, but your ARIA risk also goes down. So that's the conundrum we're facing, and there are some new scientific advances that people are working on to try to solve this. So what are the main mechanisms underlying ARIA? We still don't fully understand it, and this is an area, again, that I know the Boston group is doing a lot, especially Dr. Bowman and his group is doing a lot. So one of the major risk factors is called cerebral amyloid angiopathy. Again, this is not a well-understood condition. It's simply put, it's accumulation of amyloid in small and medium-sized blood vessels. Usually these blood vessels are already damaged by hypertension and atherosclerosis, and then you have accumulation of amyloid as a result of small tears and other problems, and that makes the vessels very vulnerable for rupture and bleeding. It's thought the complement pathway is what's activated, at least based on rodent studies, but we fully don't understand in humans all of the mechanisms, why some people get it, why others don't get it, why it occurs early in some cases, why it occurs late in others. We know circulating amyloid antibodies might play a role, but again, we don't fully understand how and why. So the other risk factor is the concurrent use of antithrombotic agents. This is a very rare, severe case of a person who developed a stroke while getting lecanemab. And then the doctors at that time attempted to treat the stroke using TPA, an antithrombotic agent, which actually worsened the ARIA, resulting in multiple areas of hemorrhages in the brain and the person eventually dying. And you can see again here, the amyloid deposition around the blood vessels. You can see the multiple hemorrhages that this person has. So again, we want to avoid these conditions if at all possible. So this is my last slide on the first part of my presentation. So this is the FDA boxed warning that these drugs can cause ARIA. The incidence and timing of ARIA vary among patients. So this is a big challenge. Can we develop predictors? And can we develop tools to better monitor instead of having to we can't do an MRI scan every day or every week in these patients. Now, the more often you do MRI, the more you might detect these. But can we detect other kinds of predictors so that we know right up front which patient is likely to develop ARIA and which patient don't? The other problem we don't understand is, when does ARIA fully resolve? And how do we manage someone with ARIA? Do we stop treatment? Can we resume treatment? And what is the right green signal for us to resume treatment? So those are some of the conundrums where we need more research on. So at this point, I want to invite my colleague, Dr. Andy Liu, to present the results of the Duke real-world study.
Thank you, Murali. What I'm going to do is kind of talk about three things, if you can go to the next slide. First one is safety. How safe is lecanemab in the real world? The severe adverse events such as strokes, deaths, hospitalizations, we'll touch on that here in a few slides. On top of that, we're going to look at the ARIA rates in the real world. In our clinic, we don't have as many, I guess I would say, exclusion criteria versus the clinical trials. So the outcomes in terms of incidence of ARIA seem to be, well, what we are going to report here in a few slides. And then, of course, the last one is the effectiveness of lecanemab in terms of long-term cognition. How does ARIA affect people's cognition? It's a common question I get in the clinic, is if I develop ARIA or a severe adverse event, how is that going to help me or detriment me in the long run? So hopefully all of these lessons will provide a framework for a lot of the clinics out there that are hoping to establish anti-amyloid therapy clinics, specifically in the EU, because a lot of this lecanemab was actually just approved in March of this year. And so I think a lot of clinics are still trying to get their clinic up to speed and determine how safe is lecanemab. Next slide, please. To give a quick overview in terms of how we do it here at Duke, we will do a clinical evaluation and diagnose patients with either MCI or Alzheimer's disease. After that, we're going to start really looking at all the biomarkers shown here. So a baseline MRI to make sure that there's no structural causes, superficial siderosis, CAA, etc. We're going to confirm AD pathology either by CSF or by a florbetapir PET scan. And then lastly, we're going to do the ApoE genotyping. This is all standard practice for all clinicians in our group right now. After all of this is collected, we bring the patient back about a month later and then describe the risks, the benefits, the alternatives of lecanemab. If they are okay with this and there's no contraindications, we will place the order for lecanemab in, as well as the MRI surveillance scans, as you can see, before the 5th, the 7th, and the 14th infusion to look for ARIA-E or ARIA-H, either microhemorrhages or superficial siderosis. So that's kind of the layout right now. Next slide, please. In terms of the real-world data, what we reviewed from May of 2023 through March of 2025 is 230 patients currently on lecanemab. We have over 300 now, and we follow them up to 18 months, shown here in these few points here. The mean age is about 74, and about 50% are female. 12% were found to be homozygous for E4. 55% were found to be heterozygotes, and then 33% were non-carriers. In terms of adverse events, we did have 5 deaths, 2 which we thought were directly related to lecanemab. One had severe ARIA-E and leading to status epilepticus, and the family decided to withdraw care. The second one was a macrohemorrhage that Dr. Doraiswamy had mentioned earlier, and then the patient had passed because of that. There were 3 other deaths. One was due to abdominal cancer, another one was failure to thrive, and then the last one was a PE. Now, the PE may have been related to lecanemab. It's unclear, but about 2 to 3 deaths were found in our clinic at this point. So about 1% death rate, which is similar to what was seen in the clinical trial, the Clarity AD trial as well. We have 61 significant or severe adverse events. That was defined as hospitalizations, ED visits, stroke, seizures, urinary retention, etc. We have 58 cases of ARIA from this group right now, 48 of which were ARIA-H, which includes microhemorrhages or superficial siderosis, and 22 with ARIA-E. It should be known that a lot of them actually had both. So they either had microhemorrhages, they had microhemorrhages with edema for a lot of the cases. Next slide, please. I want to quickly go over the radiographic features of ARIA. Specifically starting with this one, ARIA-E, and looking at the different severities. So those not familiar, when we look at the scans for ARIA-E, we're looking specifically at the size and the number for ARIA-E. So for a mild case, it's less than 5 centimeters, as shown in this arrow here, in the top left panel. And the middle row, for the moderate cases, it can be either one area between 5 to 10 centimeters or 2 separate areas less than 5 centimeters. So that's why I illustrate the 2 arrows here, 2 separate areas that seem to be less than 5 centimeters at this point, fulfilling the moderate definition of ARIA-E. And then severe is 10 centimeters or greater, kind of outlined in this crescent shape right here. Next slide, please. The next one is the microhemorrhage category, and this is purely based on the number of microhemorrhages that we see. So for the mild cases between 1 and 5 microhemorrhages fulfills the mild definition. Moderate is 5 to 9. So you can see these 4 in this kind of left anterior temporal lobe and 1 on the right anterior temporal lobe fulfills moderate criteria. And then in this oval shape, you can see that there's several microhemorrhages in the parietal lobes. So you need 10 or more, which this fulfills at this time. Next slide. Last one is the superficial siderosis subtype. And this is purely based on the number of regions that are involved. So with one region shown in this arrow, it is mild. 2 separate regions, it is moderate. And 3 separate regions in this bottom right panel is a severe case of ARIA with superficial siderosis. Now, going into our data, next slide, please. I want to introduce kind of the ARIA incidence by ApoE genotyping. So a lot of the clinic patients are very scared if they have only one copy of ApoE, which is, like I said before, 55% of the people in our clinic. And what we did was look at the data and looking at people with any ARIA or these 3 different subtypes of ARIA and determining the people who have ARIA, who are present, or do not have ARIA, which is absent. You can see the odds ratio and the p-values for people with 2 copies of ARIA-E or 1 copy of ARIA-E for each category below. And as you can see, and consistent with the literature from before, people with 2 copies are far more likely to develop any type of ARIA, but also any subtype, as you can see in this slide going across. Even with 1 copy, there is a higher risk compared to people without a copy, as you can see going forward here. You could just add up the present versus absent for 100%. So it's almost an exponential increase in terms of the number of copies and the incidence of ARIA based on ApoE genotyping. People are at risk, but that does not mean they will absolutely develop that. And I'll talk about why I mentioned this here in a couple slides. Next slide, please. Next, we look at the incidence of ARIA based on the clinical diagnosis. So again, kind of the same thing, any ARIA versus, and then all 3 different subtypes, and then looking at the odds ratio and the p-value, and people who have ARIA versus people who do not have ARIA. So consistent with the WashU group, people with a diagnosis of Alzheimer's disease seem to have a higher incidence rate of ARIA, regardless of the subtype. And then when you compare any ARIA type to people with MCI, you can see it's much higher. And I think that makes sense mechanistically because people with Alzheimer's disease should have more Alzheimer's disease pathology, making them have an increased risk of developing any type of ARIA going forward. Next slide. We then looked at the sex. I think Previously, it was reported that the female sex was at a higher rate of incidence of ARIA. I think Steve Salloway's group looked at this for the gantenerumab anti-amyloid last fall. Our data seems to be showing something a little different. Again, kind of the same setup. Any ARIA versus the three subtypes present or absent with the odds ratio and p-value shown above. And so when we look at the males shown kind of in the salmon colored versus the females in the teal colored, the males seem to have a higher incidence of ARIA across the board. But these p-values seem to be very high. I think the ARIA-E seems to be trending towards significance. And so I think, well, only time will tell. I believe this will probably be very close to 50-50. I don't know if sex is going to be a huge difference, but right now what we're seeing is that males seem to be a little higher risk at this time. Next slide, please. So this is just kind of a table that shows all of the data that I was just describing at this time. For the total number of patients, the 230, the average age was about 74, so a little older, marginally older compared to the Clarity AD trial. The Clarity AD trial had an average age of 71. And so you can see it didn't matter what type of ARIA, the age was about the same. So I wouldn't counsel patients on saying as you get older, you're more likely to develop any type of ARIA or subtype of ARIA. And then, as I mentioned earlier, the female and male sex, there doesn't seem to be a huge difference, but trending a little towards the males at this point. Generalizability is a little difficult for us because our population who are receiving lecanemab is primarily white at this time. But what's interesting down here is the A beta 42 over p tau 181 over 42 ratio. Both of these are from CSF. And so for reference, the A beta 42/40 ratio has a normal value of equal to or greater than 0.073. So, of course, all these people would have it lower than that, suggestive of AD pathology. Those not familiar, CSF A beta 42/40 ratio has to be low for people with Alzheimer's disease pathology. That's because the 42 protein is very sticky, stays in the brain, and is not very high in the CSF. And so when we compare the any ARIA to the no ARIA cases, it seems to be a little lower. And then in the ARIA with superficial siderosis and microhemorrhages, you can see it's a pretty significant change there, which makes sense, again, going back to the pathophysiology. The more A beta 42 you have in the brain, the more likely you're going to develop ARIA. P tau 181 over 42 ratio, there didn't seem to be a change between the no ARIA and ARIA cases for their value. For reference, a normal value is less than or equal to 0.028. So this is about a five-fold increase compared to the normal reference value. And this one, there's a correlation. The higher value means more pathology. And so I don't notice a difference there, but I think I'll touch base in terms of what we can do to use this as a predictive value as well. And then the last one is the Physicus score. And so Physicus score is just the amount of white matter changes, which I'll show you radiographically here in a few slides, and how we can use that to determine who might develop ARIA versus not. And so any ARIA case versus no ARIA case, there doesn't seem to be a huge difference there. Next slide, please. A big question from patients and clinicians are, when will they develop ARIA, by what subtype, and then how severe is it going to be? So the panel on the left really shows you the different types of ARIA, the three different subtypes. And so usually within the first 15 weeks is when we see all three different types, with ARIA-E being the most frequent. The y-axis is density, which also kind of shows you the number of cases that we will have after starting infusion, which is the x-axis, the number of weeks here. And so you see kind of an extra bump between 20 and 30 weeks. And I think this is because when we detect it in the first kind of 12 to 15 weeks, we'll continue to monitor them. And sometimes they develop another area of ARIA-E or microhemorrhage or superficial siderosis, which is why there's this second bump here. And then over time, excuse me, as the body gets used to this anti-amyloid medication, the types go down. And consistent with that theme, the severity is very high in the first 15 weeks. So the severe cases really are the first 15 weeks. So counseling patients and clinicians and saying, this is when you're most vigilant, which is why we have the surveillance MRIs in this time period is the most critical. The FDA just updated the recommendations in terms of trying to get another MRI after the second infusion to try to catch people right at this area too, which I think is justified, and we're trying to implement that here at Duke right now. But you can see mild and moderate, again, kind of a bimodal distribution specifically for the moderate, and then the mild kind of goes away with time too. So I think these right here, there's outlier cases, but they seem to be mild, and not all the mild cases require hospitalization. Next slide, please. We saw a handful of patients, and this is important because a lot of people are asking me, if I do develop ARIA, how long does it take to resolve? For the handful of patients, the vast majority of them did resolve after about 10 weeks. Only 2 of them required more than 10 weeks and a little more than 20 weeks. And it's usually the ARIA-E or microhemorrhages that we saw that required a little more time. And we typically did this with surveillance of MRIs every 2 to 4 weeks, depending on severity. So another question, next slide, please, is what will this do to my cognition or, my brain function going forward? When we looked at the people without ARIA who are on colored by the salmon color, and then people who did have ARIA colored by the teal color, when we looked at their MMSE or their MoCA scores at 0, 6, and 12 months, we did not see a lot of change, specifically in the MMSE scores. These kind of dash markings show the confidence intervals for here. On the MoCA score, there seems to be a little dip in the MoCA, but a wide confidence interval. And this really just reflects the fact that our group really prefers the MMSE versus the MoCA. There weren't as many MoCAs as the MMSE. So I think that'll tighten over time as well. Next slide. Now going into predictive factors. So when we looked at the ROC curves for the CSF p-tau 181 over A beta 42 ratio, we with 157 patients that underwent a lumbar puncture, the AUC was 0.85. And so that seems to be a pretty good predictor in terms of who is going to develop ARIA. I'll touch base on that. I'll make a few more comments in a few slides. Next slide, please. We also look at the Physika score. So as you can see here, it's graded. There's a 0 where there's nothing at all, and then grade 1, 2, and 3 with increasing severity. And so based on the Boston criteria for a CAA, more white matter changes is also possibly suggestive of cerebral amyloid angiopathy. So we're hoping that that could be a predictive factor for ARIA. The AUC curve for this Physika score was moderate at 0.69 for all the patients that we looked at right now. So I don't know if we can absolutely predict it with a Physika score, but I think there's utility still with the Physika score I'll mention in a few slides. Next slide, please. Now, so modeling results, what we did was use these 6 factors, and we used something called a UDIN index to try to optimize sensitivity, specificity, and help predict the positive predictive value, negative predictive value, sensitivity, and specificity. So we, of course, looked at the E4 allele, and the negative predictive value was quite high, which is consistent with our results here. So if you're a non-carrier for E4, the likelihood of developing ARIA is lower. However, if you have 1 or 2 copies, it is much higher. The positive predictive value was not very good. So what I would say with this result is that someone with an E4, I would counsel them in the clinic and say, as a group, the risk of developing ARIA is much higher. but at an individual basis, I cannot tell that person whether they will develop ARIA or not. So I think that's the distinction here with the data that we have right now. Now, conversely, though, the p-tau 181 over A beta 42 ratio, I think there's a much more potential in terms of predicting at the individual level who will develop ARIA. And so, like I said, 157 completed the CSF analysis for this ratio and with an AUC curve of 0.85. When they fulfilled this rule for that UDIN index, the positive and negative predictive value were very high. Specificity was also high. So what that means is that if you have a specific quantitative ratio, I can predict whether you will develop ARIA or not, specifically because of lecanemab infusions, So I think that's going to be an important thing going forward. However, as I mentioned before, the p-value is not significant at this time, so we'll need further confirmation of this. Physika score, as I said, the positive predictive value was not very high. The negative predictive value is quite high, though, and the sensitivity is quite good. So what I would say with this is that someone with a higher Physika score and a high, p-tau 181 over A beta 42 ratio, combining those two might clinically inform the clinician and the patient that they might develop ARIA going forward, especially if they have at least one copy of E4. Next slide, please. So this is just my last slide before I hand it back to Dr. Doraiswamy in terms of how we triage patients for ARIA. So ARIA and actually severe infusion reactions. So with symptomatic ARIA or severe infusion reactions, we send them to the ED. Asymptomatic ARIA found to have moderate or severe MRI brain changes, they also go to the ED. Now, with these two groups, the severe infusion groups and the symptomatic ARIA patients, they will go home if their symptoms improve. The asymptomatic, moderate or severe ARIA cases will always be admitted for further monitoring because we will provide them with oral or IV steroids. We'll repeat imaging to make sure that things aren't continuing to worsen or they develop new symptoms as well. So I think that's kind of how we triage patients at this point. And thankfully, we have not had too many of those people going forward. So next slide, please. All right. I'll hand it back to Dr. Doraiswamy. Thank you.
Thank you, Andy. Just the last few minutes, we're living in the era of ChatGPT and GPT-5. So naturally, we were interested in this question, can an AI tool enhance safety during treatment with anti-amyloid therapies? So very recently, there's a new tool called IcoBrain ARIA, which was developed based on convolutional neural network, which was granted FDA clearance as the first AI CDS. CDS means clinical decision support. So it's not a self-driving car, but it's intended to provide decision support and guidance, and the physician has to make the ultimate decision. So it just shows you what it does here in these slides here. It's very pretty, actually, because it automatically highlights and flags for you the different types of ARIA, the size of the ARIA, gives you the location of the ARIA, and you're able to serially compare it over time. So it's really very handy, and so the question is, how effective and useful is this tool? So one of the reasons for developing this tool is that many ARIA cases tend to be very tiny, isolated lesions that may be easily missed. Radiologists, just like all humans, vary very widely in their inter-rater reliability. And again, the goal is that if we can detect ARIA early, we can avoid unnecessary harm. We can avoid it from potentially getting bigger and resulting in a serious clinical effect. So in the pivotal validation study, 16 board-certified radiologists were asked to review 199 MRI scans from an antibody trial. They were first asked to read it without having the AI tool, and then they read it with the AI tool. And here's what they found. They found that radiologists missed 29% of ARIA-E and 31% of ARIA-H cases, including some 50% of mild cases when they read the scans without the AI tool. So when they read it again with the AI tool, they were able to spot these cases, and the number of cases that they missed dropped to 13 and 21% compared to a gold standard. Also, the inter-rater reliability of radiologists ranged from 0.6 to 0.7 when they did not use the AI tool, and this increased by about 10 percentage points when they used the AI tool. So we wanted to evaluate this at Duke. So we did an initial evaluation. The left side just shows you what it looks like. You can see how easy it is. With the naked eye, you'll have to sort of look for these shades of gray, black, gray, whereas with the AI tool, it colors it, digitizes it, and not only that, it prints out a report saying how many ARIA lesions there are, what's the size of the lesion, what's the exact cortical location of the lesion, and you're able to easily compare it from one scan to another. So we looked at 73 MRI scans done at Duke from 23 patients who were receiving lecanemab. And what we found was that in 42% of the patients with ARIA, it was only flagged on the AI reads. So, and some of these were clinically irrelevant. Some were like really small that were missed by the radiologist that then later on in subsequent scans went on to become bigger. But the cons were that AI also flagged some false positives, such as artifacts and old baseline lesions that it considered new. And it didn't always work. So you can see out of 73 scans that we put through the AI tool, it could only analyze 66 scans because the scans had used different sequences, pulse sequences that were not compatible with the AI. So the ultimate question is, does this increased sensitivity enhance patient safety? And that has not been fully addressed, and that's one of the studies I think that needs to be done. Is it simply picking up sort of minor lesions that are inconsequential, or is it picking up lesions that can truly sort of enhance patient safety? So one of the lessons from our AI studies that is really important to standardize MRI referrals and sequences. And I'll give you an example on this image. On the left side, you see a scan done using the standard sequence that was used in all the clinical trials. It was called GRE, or gradient recall echo. But if you do the scan using susceptibility weighted imaging, which is much more sensitive for picking up microhemorrhages, you can see how many lesions were picked up that were not picked up in the previous scan. And so there's actually a paper that was just published where they created a simulation of what the higher rate of ARIA would have been had the trials been using SWI instead of GRE. And they concluded that the rate of therapy discontinuation would have increased by more than 50% compared to the rates reported in the prescribing information. Now, again, that is a conundrum that we face. At Duke, we are currently using SWI, but again, I think this is something that the field needs to come up with an agreement on. And this just shows you how we standardize the protocol at Duke. We sort of have these boxes that clinicians can pick to just make it easy for them to standardize. So in the last 1 minute, I just want to touch upon a project that Andy and I are beginning, which is instead of doing expensive serial MRIs and instead of the uncertainty of knowing who's going to develop ARIA and who doesn't, can we develop a tool based on blood-based biomarkers at baseline that can predict and can also be used to track ARIA? So here are some of the blood-based biomarkers that may be relevant to either prediction or monitoring. In the first bullet point, I'm showing you some of the blood-based biomarkers that in the literature have suggested might be able to predict CAA, which is amyloid angiopathy, cerebral amyloid angiopathy. And then in the next 4 bullet points, some potential biomarkers that we are looking at that might be able to predict and monitor ARIA. For example, UCHL1 and GFAP, we know they can be useful in acute brain injury cases. Can they be useful in ARIA? So we undertook a targeted proteomics exercise, but we were limited by a small sample size. So I'm just going to show you one slide of our summary findings. This is, we did SomaLogic in this particular slide, which used targeted 1,500 proteomic markers. We have another study with more CNS-specific markers using Alamar's panel, which we're not showing today. But these are the top 10 that came out. Now, of course, when you subject these, this is a univariate analysis. If you subject them to multivariate, FDR correction, many of these disappear. So the problem, again, is limited sample size. So some of the ones that came out were metalloproteins, some cytokines, some angiogenesis and vascular factors such as VEGF, nerve growth factor, etc. So again, so that's just initial pilot results. We'll hopefully have more definitive results very soon. So I just want to conclude. Basically, I think what we found in our real world study is, as Andy presented, there are very specific factors that seem to influence the ARIA incidence rates, but there's still some things that are unknown. Lecanemab was relatively well tolerated in the majority of subjects, but again, careful monitoring is still warranted given the risks in a minority. In our study, efficacy was not significantly different amongst those with and without ARIA. Again, a bigger sample size is needed. CSF p-tau over A-beta 42 ratio has a high positive and negative predictive value for ARIA. Fazika score has a high sensitivity to predict ARIA. Again, the hope is that newer titration schemes and delivery forms may help reduce ARIA rates, but I think we really need more research. This is very urgent need of the hour to enhance safety in order to maximize the benefits of these breakthrough drugs. So with that, I'm going to stop. I'd be delighted to take questions from the audience. And these are our collaborators that we worked with on this project, the Duke UNC ADRC, as well as a number of others, Mogi, Dr. Jeff Petrella, Mike Lutz, Samsul Alam. Their help was invaluable. So I just want to thank you.
Okay, thank you very much, Dr. Doraiswamy and Dr. Liu, for your presentation. Very interesting around ARIA. I know there are a couple questions in the chat. One here by Dr. Du Kim. I don't know if he's still on the call. He'd like to present his question. Du?
Oh, yeah. So it's a very nice talk. Thank you very much. So I have some basic mechanistic questions. Lipoprotein is very important trafficking of lipid. And previous ApoE knockout mice model shows hemorrhages and vascular problems before. So theoretically, that ApoE4 has high affinity towards A-beta oligomers and fibrils. So these antibodies with high levels can potentially deplete these beneficial blood lipid transporting molecules. And that could also explain the vascular problem we are seeing in here. So did anybody ever look at local cholesterol problem depletion trafficking or functional the ApoE protein levels and others?
Yeah, so I'm not familiar with any studies where, these anti-amyloids were given to ApoE4 carriers. I think that seems to be the question is, what is the effect of anti-amyloids on ApoE4 heterohomozygotes? And I'm not familiar with that case because I think if they're very specific, so I would probably guess that there's not a lot of damage related to the lecanemab or other anti-amyloids related to that, but more directly related to the abnormal trafficking of ApoE4 and the function of ApoE4 itself.
So one thing directly testing this hypothesis is that when the previous wild type ApoE knockout models, they see local accumulation of cholesterol, especially around the blood. So that blood dysfunctions came from the cholesterol and other lipid cargo. It just accumulate blood walls, and that leads to the damages. And that's a basic model of these vascular damages. Maybe this is the kind of things they can check it out, right? I don't know whether there's any studies serum cholesterol levels, but I think that's a general panel. So if there are changes in beneficial lipoprotein pools in general, and you should see some changes in the serum cholesterol panels.
Yeah, absolutely. I think future studies would be greatly welcome. It sounds like a potential collaboration with anyone who's studying ApoE. Of course, ApoE4 was discovered here at Duke, and there's a lot of people working on it right now. But I think it'd be very clinically relevant to kind of tease that question out for sure. Thank you.
Just to add to that, in the pivotal clinical trials, there were no significant changes in any laboratory values related to lipids after administering these drugs. But they may not have measured all the ApoE variants in the blood that you are talking about. They just measured the main clinical labs.
Got it.
Rudy, you have your hand up?
Yeah. Oh, great, really great talks, Raleigh, Andy. It was, I've never seen in one talk so much incredibly new and valid information on ARIA, and to just thank you very much for that. And
Thank you.
I, you know, there was always this theme that the more cerebrovascular amyloid angiopathy you have, the higher risk for ARIA, and that ApoE4 homozygotes have more CAA. So I guess I have two questions, and then might have a third question unless somebody else asks something right away. But there are companies that are focusing on immunotherapies against oligomer versus fibrils, arguing that they have preliminary data that if you target the oligomer and not the fibrils, that you avoid your monoclonal antibody from hitting CAA, where they argue if the antibody doesn't get trapped on vessel amyloid, that you will avoid ARIA, avoid vasogenic edema, avoid microhemorrhage. So I'm wondering, first, what is your experience with that? And second, are we just directly imaging for CAA and making decisions about suitability for immunotherapy and E4 homozygotes that way as well? Are you guys directly doing that? Is there a way to really know if there's a threshold SUV for CAA that says you're an E4 homozygote, you have too much CAA and you're not eligible? So those are the two questions.
Yeah. So to address that last question, what we do is definitely use that cutoff of 4 or less microhemorrhages if they're seen, based on the appropriate use recommendations from Jeff Cummings' group that was published a few years ago. I think also there was another clinical trial, I think using gantenerumab, there was one superficial siderosis that led to a macrohemorrhage. So
I know they use microhemorrhage, but I'm saying something different. I'm saying in the absence of microhemorrhage, is there a way to just look at a threshold level, an SUV for CAA itself, that says as an E4 homozygote, you're on the high end or low end of how much chondrophilic amyloid angiopathy you have. And the more you have, the higher the risk that you're going to have ARIA E or H. Is anyone doing that, not besides looking for the overt microhemorrhages that are there?
Yeah, no, I think I think what we do is, so we don't exclude anyone who's homozygous for E4. Some people do. What we do is just counsel them on a one-to-one basis to say, you're just at a higher risk. I think definitely a lot more research has to go into saying, you know what, your risk based on, your CSF, your amyloid PET scan, things like that, that will help us determine what the risk of developing ARIA is. I think the florbetapir PET scans, now that they're being quantitated, that's going to be an interesting area to help correlate ARIA, especially in these homozygote patients.
But even there in the E4 homozygotes, if you have a sense of the relative amount of CAA.
No, Rudy,
and you're not turning them down, but could it tell you how often you should do MRI? Maybe more often than another patient.
So Rudy, I think the research being done in CAA is it's an urgent, it was in the backwaters, right? As you know, until recently with the introduction of these drugs, that's when CAA has really come to the forefront and it's become much more urgent. So that at least about a dozen groups developing biomarkers of CAA and more sensitive MRI imaging parameters. So currently, unfortunately, that standard CAA detection in the clinic is almost like a de facto, like you wait for hemorrhages to happen, microhemorrhages to happen, or macrohemorrhages before you really start someone on the workup for CAA, unless there's a known prior history. Now, what's even more alarming is there's new studies suggest that virtually every surgery can simulate sort of CAA formation. So there's some new research coming out suggesting that, neurosurgery, especially like in children, certain types of cardiovascular surgery, all that can sort of stimulate CAA. And the CAA Boston criteria too has actually lowered the threshold for who has CAA. So a lot more people are going to have CAA, and there's a company working on an AI algorithm to detect CAA automatically from MRI scans, which will address the issue that you mentioned. So somebody has ApoE4 homozygotes, and the MRI flags it. If they order that sequence, it flags it, then that again then will, the clinicians have to decide. Now, the tension there is you don't want to deprive too many people of drugs, otherwise we'll start depriving everybody of their drugs. So where do we draw the line? And that's the tension in the field.
So the other question, and I know Gene has his hand up, but the other question is, do you have evidence or do you believe that immunotherapies are targeted against a liver versus
With
five
oligomers?
have less ARIA?
Yeah, so we don't have any evidence that says that the lecanemab is targeting only soluble. I think subsequent lectures that I've seen at CTAD and others have shown that it's actually both. It's soluble and insoluble forms of A beta. So I don't think it'd be very hard to target just the soluble forms and prove that. I guess we could do that with repeat CSF analysis. We don't do that because patients, of course, are very resistant to a repeat lumbar puncture that doesn't change the management. But what I would say is donanemab, on the contrast to that, donanemab only does the plaques, so the insoluble forms, and they seem to have a much higher risk of developing ARIA. So,
and there are companies right now claiming that if they target a oligomer and avoid fibril or even protofibrils, that they will reduce or even remove the chance for ARIA. And
it's possible. It's possible.
Yeah.
What I would say though also is this. I mean, the clinical diagnosis hints at this, is that AD should have more pathology than MCI. And so with Risa Sperling's, AHEAD study, the earlier we go, the fewer ARIA cases we should have, And so I think that's going to be the important thing, is based on the NIA's new criteria for Alzheimer's disease. It's not based on symptoms anymore. It's purely based on biomarkers. So people who have low A beta 42/40 ratio already, if we start them on anti-amyloids before they're symptomatic, what percentage of those patients will develop ARIA? I think that's going to be an interesting question going forward.
Looks like Gene has a question.
Yeah, thank you, Rudy. So I know you had presented some data here today around the Phasica grade as a predictor of ARIA. But more specifically, looking at the periventricular versus the subcortical deep white matter lesions, do you see a higher prevalence in the periventricular white matter lesions as in terms of being a predictor of ARIA, or is it? I know you looked at, I think it was the total score you were looking at, but differentiating those regions within the brain around the ventricles versus subcortical deep, do you see any differences there in prediction of ARIA?
Very interesting question. I don't think we're powered enough to kind of differentiate people who have the periventricular white matter changes versus subcortical white matter changes at this time. I think we have very small numbers with either of them. And so I don't think statistically we would be able to conclude a lot right now. I think as the population grows, it will definitely increase.
Okay. I mean, there is some evidence to suggest that, there's different pathophysiological events in those two presentations. Another reason I bring it up is that, the omega-3 fatty acid trial that I mentioned earlier, we see effects only in ApoE4 carriers, which was surprising, and we had pre-specified that in terms of slowing neuronal integrity breakdown. But we also have another paper that's developing where we see a certain threshold that people reach with these omega-3 fatty acids, specifically EPA and DHA, found in concentrated in fish oil, that they seem to, if an individual gets at a certain level in the bloodstream, whether that makes the pool more available to the brain is to be determined. We don't have any direct evidence of that. But nevertheless, regardless of ApoE4 genotype, we see a reduction in periventricular white matter lesions as early as the first year, a 50% reduction. And we did not see the effects in the intention to treat in the entire population, suggesting a fairly large effect. And even the preliminary data that supported and justified the trial in the first place, we see that EPA plus DHA combined in the bloodstream explain about 25% of the variance in white matter lesions in non-demented older adults. And it seems to be really related to periventricular specifically. And also related to Do Kim's question about some lipids that might be relevant, potentially a fatty acid profile in the bloodstream, particularly if you have individuals there at Duke that are also working specifically on ApoE genotype, that there might be some link here. And also Rudy's group has generated some in vitro data showing that EPA plus DHA have robust reduction of microglial activation and release of pro-inflammatory cytokines, providing some mechanism there.
That would be fantastic to study that further and see if co-administering that with the antibodies reduces the risk for ARIA. That would be life-saving for the companies and for patients.
Yeah, so it may be that, it seems to take about 3 months to load an individual based on their baseline levels, but in general, to really reform the
it takes us a month and a half to get people through the pipeline to start treatment, so they have plenty of time to get loaded on that, and that may be a great option.
Yeah, so that could potentially be something, we weren't really targeting, reduction in ARIA, but now that we see the results from these trials enrolling and there's a wonderful safety profile. I mean, even in this trial, we had people that had significant white matter lesions as an inclusion criteria. It was quite safe, and tolerable, which we had major concerns at the onset of the trial, whether or not EPA specifically was affecting the platelet aggregation and into bleeding in the brain.
And we have no good treatments for CAA as well, so
And I think the population down here, the vascular risk factors are far more prevalent than in other places of the country. So I think it'd be very relevant for our clinical population at this time.
Right. We're in the stroke belt.
Yeah, right. Well, maybe that's something we could talk about further.
Absolutely. Would be delighted to.
Okay.
It's a great idea, brilliant idea, That's why I was hoping when I did this talk that somebody would come up with.
Well, thank you so much. We've gone over time here. I don't see any other questions, but thank you for taking the time. It's wonderful to meet both of you, and welcome to the McCann Center Seminar Series. We hope you come back.
Thank you.
Thank you. It'd be our honor.
All right.
That was
Thank you,
great.
everybody.
Thank you, guys. Really great.
Thank you for inviting us.
Okay. Take care. We'll be in touch.